Good afternoon, everyone, and welcome to ISHRT. My name is Lisa Anderson. I'm the president of Paragonix Technologies. It is a privilege to open this session, a higher standard, modern innovations in elevating lung preservation. And I'll say this up front, this is one of the moments where the field isn't just evolving, it's accelerating. Over the past year, we've seen a level of scale and momentum that would have been hard to imagine even a few years ago. Our Paragonix Advanced Preservation systems have become the new standard of care in thoracic preservation, supporting over 50% of all heart and lung transplants in the United States. Since our products launched, that's more than 22,000 organs, including over 5,200 donor lungs. Behind those numbers is something even more meaningful: more donors honored, more recipients transplanted, and more teams pushing the boundaries of what's possible. This growth is happening across a truly global network that we've built. 245 centers spanning 19 countries, including 70 dedicated lung programs. And importantly, it's not just about technology. It's about the ecosystem around it. Since offering surgical organ recovery, more than 2,700 organ recoveries were supported through our integrated services team, powered by a growing clinical network of over 25 transplant surgeons and over 100 surgical support professionals. At the same time, our digital adoption has surged with over 13,000 users and more than 15,000 tracked cases, giving us an unprecedented window into the real-world journey of every organ. And those who have visited our booth may have seen a sneak peek of what's still to come later this year when we introduce Trace, a next-generation software platform designed to reimagine and reconnect the entire transplant process, from initial organ offer through final transplant. The goal is simple but ambitious: bring greater visibility, coordination, and insight across every step of the journey. Now, talking about journeys, our mobile app has tracked organs for over 7.6 million miles. And since US astronauts just returned safely back from their moon journey, that 7.6 million miles translates into 14.5 times to the moon and back. Now, today's session brings together 3 leaders who are each tackling a different piece of that challenge: temperature, pressure, and logistics, and helping us better understand how these variables shape outcomes in ways we're only beginning to quantify. We are honored to have Dr. Ramiro Fernandez from Baylor College of Medicine, Dr. Osho from Massachusetts General Hospital, and Dr. Eugene Golts from UC San Diego Health. Before we begin, I also want to take a moment to recognize and thank the GUARDIAN investigators and all the clinical teams contributing to this growing body of evidence. The insights we're discussing today don't happen without your commitment to rigorous data collection, collaboration, and continuous improvement. You are not just participating in the field, you are helping define its future. With that, I'll turn it over to our first speaker, Dr. Fernandez from Baylor.
Thank you. Dr. Fernandez,
Your speaker's not on. All right, so I can introduce myself. So Ramiro Fernandez, I'm a lung transplant thoracic surgeon at Baylor College of Medicine, and thank you for the invitation to speak. It's a privilege for me to be here. I'm going to be talking about the general overview of outcomes that have come out of the GUARDIAN-Lung Registry, and I'm also going to give a sneak peek at some of the data, some of the presentations that will take place at this year's ISHLT meeting from data from the registry. So I think it's safe to say that we have officially moved past the ice age when it comes to static cold preservation. So we've entered the controlled hypothermic storage era. And there is sound evidence now that ice preservation is really not 4-degree preservation. It is not benign. There is heterogeneous cooling and exposure to freezing temperatures, which damages the lung tissue. Other groups have found preserved mitochondrial function and improved cellular health when lung grafts are preserved at moderate hypothermia as opposed to ice. Also, changing practice patterns in contemporary lung transplantation, including longer travel distances for procurement and time shifting to avoid overnight transplants, has pushed the use of controlled hypothermic storage since ice is not well suited for prolonged preservation. And multiple reports now support safe preservation times greater than 15 hours. So the LungGuard device was the first portable controlled hypothermic storage platform with FDA approval. Many of you are familiar with the device. Many of you in this room probably use it. It preserves the lung allograft between 4 and 8 degrees Celsius with homogeneous cooling for safe extension of preservation times. And there's also real-time monitoring of temperature and location. As you can see in these infrared images, which demonstrate the homogeneous cooling in the 4 to 8 degree range for up to 14 hours of preservation with LungGuard. Now, the real-world outcomes of LungGuard use are being tracked by the GUARDIAN-Lung Registry, which is one of the largest clinical databases evaluating outcomes using novel lung preservation devices. There are 19 participating centers across the country and over 200 enrolled patients to date. Now, each center also contributes ice and now machine perfusion cases as controls. So I'm going to highlight some of the important work coming out of the GUARDIAN-Lung Registry, which supports the use of the LungGuard and BearGuard devices. This data set includes lung transplants in adults between April of 2017 and August of 2025, and includes ice controls from the same contributing centers. So to begin, I'll discuss the latest overall outcomes analysis from the LungGuard Registry. This was a propensity matched analysis comparing LungGuard to ice with 304 subjects in each group. And the groups were well matched in terms of baseline characteristics. The use of DCD donors was 11.8% in the ice group and 13% in the LungGuard group. Mean ischemia time was about 7 hours in both groups. There was a difference in time shifting between groups, 18% in the ice versus 25% in the LungGuard group. And time shifting in the study was defined as recipient OR time starting after the arrival of the donor lungs. And in terms of outcomes, early graft function was similar between groups with similar PGD3 rates and post-op ECMO use. However, there was a lower incidence of renal dysfunction in the LungGuard group compared to ice. Now, in addition to better renal function in the perioperative period, the LungGuard group demonstrated fewer hospital readmissions, both overall and due to graft dysfunction, as well as a lower incidence of acute rejection up to 1 year post-transplant. So the benefits of LungGuard use may extend beyond the perioperative period. Now, as you all know, one of the main advantages of controlled hypothermic storage is the ability to prolong preservation times. So Dr. Gattier recently presented an analysis at the AATS transplant meeting last fall of prolonged preservation times using LungGuard. He compared LungGuard cases with greater than 16 hours of ischemia time to standard ice cases with ischemia times of less than 8 hours. There were 80 cases in the LungGuard group versus 280 in the ice controls. And the median ischemia time was impressive. In the LungGuard group was 19 hours versus 6.3 hours in the ice group. Now, in terms of baseline characteristics, LungGuard was used in higher risk cases. The donors were older, more had marginal function with EVOP use in 26% of cases, and a quarter were DCD versus only 4% in the ice group. There was a threefold longer ischemia times and longer travel distances as well. The use of intra-op circular support, though, was higher in the ice group, with almost a third using cardiopulmonary bypass. Despite high-risk donors and threefold longer ischemia times, the use of LungGuard for prolonged preservation resulted in comparable outcomes compared to standard ice transplants. Early graft function was similar with comparable PGD3 rates at around 15% in both groups. There's similar post-op ECMO use and comparable mechanical ventilation times. The LungGuard group did have a longer ICU length of stay. However, this did not impact overall hospital length of stay or survival, both short-term and at 1 year. Now, the LungGuard group also achieved a similar incidence of a textbook outcome compared to the ICE control. So this is a metric that's a composite of several outcomes that reflect ideal post-transplant course, including excellent graft function, meaning no PGD3, no post-op ECMO, early extubation, also avoidance of post-op complications such as airway dehiscence and renal failure requiring dialysis, and also includes early discharge from hospital. And finally, there was no difference in overall survival between groups out to 2 years. So in summary, these data support the use of LungGuard for safe prolongation of preservation times beyond what was possible in the ICE era. This allows teams to time shift for any reason with confidence. So now for some sneak peeks at the latest data from the GUARDIAN-Lung Registry that will be presented at this meeting. Dr. Hartwig will present tomorrow afternoon an analysis of transplant outcomes stratified by temperature. So this is important given the different temperature ranges achieved by different controlled hypothermic storage platforms. And the primary outcome of this study was achieving a textbook outcome after lung transplant. The study found that the ideal temperature for a textbook outcome was 6.3 degrees Celsius, which is right in the middle of the 4 to 8 degree range that the LungGuard provides. There's another study that will be a presentation on Friday, which expands the concept of textbook outcomes. And this study identified various factors that were associated with a textbook outcome after lung transplant. And one of the most notable was a mean temperature of 6 to 8 degrees during preservation with an odds ratio of 1.41. Temperature under 6 degrees was actually associated with a lower incidence of a textbook outcome. Now, many centers are now transplanting more and more recipients over the age of 70. So relevant to these evolving trends in lung transplantation, there's a study assessing outcomes in lung recipients greater than 70 years of age when LungGuard was used for donor lung preservation. And similar to the overall GUARDIAN-Lung Registry analysis, the study found that the use of LungGuard in transplants for older recipients allowed safe prolongation of preservation times while significantly reducing rehospitalizations within the first year post-transplant. There's also a lower incidence of acute rejection out to 3 months. Now, prior studies have shown gender differences in lung transplant outcomes in the ICE age. So there's a poster tomorrow describing gender differences in the controlled hypothermic storage era. And what the study highlights is that while female recipients were less likely to achieve a textbook outcome, so perhaps a more perioperative morbidity, this did not affect long-term survival. There was no difference out to 2 years, and potentially a trend towards improved survival in females compared to males. And finally, there's a study evaluating outcomes after time shifting with LungGuard, with the principal finding being that despite longer ischemia times, there was no difference in overall survival in time-shifted LungGuard cases compared to non-time-shifted controls. So I'll leave you with a list of some of the talks and posters that are being presented at this year's ISHHL meeting. Thanks. And we'll hold questions till the end.
Thank you, Dr. Fernandez. I'm now pleased to introduce Dr. Eugene Golts from UCSD. He's the Surgical Director of Lung Transplantation. Dr. Golts.
Thank you for the kind introduction. Let me see. So, yes. I'm going to talk about the overcoming the logistical challenges with our preservation as it relates to the medium-sized program in the United States. First is a look back all the way up back to 2023. As you can see, kind of like was a introduction of the CAS, the importance, the travel kind of benefits or the benefits of lower distance traveled has gone away. As a result, you can see that we travel exponentially longer distances since the introduction. And what that does is, for the program, what it does, it introduces variability. And in my opinion, variability is kind of like the killer of consistently excellent outcomes. So our program, we're located on the West Coast. But now we have to travel. We can travel anywhere in North America, including outside of the country. We travel to Hawaii, so it gives us kind of like a 2,200 mile radius, and we've taken a lot of lungs from the East Coast as well. As a result, as I mentioned, the variabilities becomes kind of like the ways of deal with variability become very important. Now, where the variability comes from? In 2023, essentially, our program had to work with two OPOs. It was Life Sharing and One Legacy. Those are big OPOs, like especially One Legacy is a big OPO in the LA area. But most of our organs came from there, and we knew exactly the way they managed the organs pre-procurement, and we learned how to deal with that. Now we're in contact with OPOs throughout the country. Now the society has done a tremendous work with the creation of the guidelines, but even within the guidelines, there is a significant regional differences in managing of the donors preoperatively. In addition, long gone are the days when we were able to send a team of, we had several procurement surgeons that were all trained in a very similar way, all managed the donors in a very similar way. Now we're increasingly relying on the outsourcing of the procurement. That introduced another dimension to the variable management. With the recovery technique, the same thing. It's kind of like the maximal pressure that the lungs are inflated to. The recruitment maneuvers in the operating room are quite different between the surgeons. We try to communicate, but it still remains a source of variability. And essentially, 4 out of 5 lung sets are traveling by air, which obviously exposes the lungs to quite different environmental characteristics. So now, this is not a new area of research, and this is the study. This is from Columbia from more than a quarter of a century ago, where they have demonstrated in the lab settings that the optimal pressure for preservation is 10 millimeters of mercury, which roughly translates to 13.6 centimeters of water pressure, which is right within the 12 to 15 centimeters of water pressure range established by the society as a guideline, and that lungs on room air do better than lungs inflated at 100% oxygen or with no oxygen. Coincidentally, there's something that I didn't mention in this on this slide. They also showed that the temperature was 10 degrees was the optimal temperature for preservation. So every new findings is kind of like well-forgotten old one. This is from 1999. Now the BaraGuard is a spectacularly similar slide to the first presenter, but it allows us to manage the airway pressure actively. It provides a very good temperature control. It allows us a data transmission and kind of like communication between the lungs and the implanting team, and provides the constant supply of the conditioned room air. Now, what it does is just pumps the air in the lungs and releases the excessive air out, maintaining the pressure at the preset level. As you can see, if the pressure in the lungs is lower than the pressure outside, the pump actually adds the air into the system. At the target temperature, nothing happens. At the target pressure, nothing happens. And with an increase in the lung pressure compared to the pressure outside, the pressure is being, the air is being vented using the PEEP valve. Now, the nice thing, the company has done a tremendous job, I think, in making sure that the BaraGuard is widely available. They don't charge any additional fees, even if the organ is no go for the delivery of the device or deployment of the device. Excuse me. It's incredibly simple to use. The learning curve is very flat, so it kind of removes the requirement for the training for having a highly sophisticated and well-trained team to store the device to store the lungs on the Beauregard. What it also does, it brings the pressure kind of like within the time of the procurement. It brings the pressure gradually up, but within a very relatively short period of time, to within the range which is suggested as the optimal range for the storage. This slide has been used a bit. I used it in the past, and you can see in the red there is the red line on the screen. You can see what happens to the lungs when the pressure is not controlled. What you don't see is on this slide is that blue line that is basically very well hidden within the range of the recommended pressure, because this is what happens with the Beauregard. The pressure stays nice and stable, and there are no significant spikes. There's no drops in the pressure, so it's very controlled environment. Now, if you look at what happens to lungs in air transport, we actually had a nice video of it, but it would take too long, so kind of like went with the stills. But you can see that the lungs, as the time goes, the lungs actually continue to deflate in the preservation. So the Beauregard kind of is designed to counteract this device. Now, the next case is not our case, but it very well could have been ours. I was actually involved in one of the procurements when we had the cabin depressurized, and don't wish it to anyone. But this did happen in one of the flights with the Beauregard, and we don't have the record of what happened to the folks who were procuring the lungs and traveling with the lungs, what happened to their airway pressure. Fortunately, everyone seems to have been okay. We do have the record of what happened to the lungs themselves, the donor lungs, and as you can see, the pressure lines, they stayed nice and stable. They were able to switch the planes and implanted the lungs, and things went okay. Now, in the spirit of kind of stealing Dr. Hartwig's wind from tomorrow, you can see that the Beauregard is actually maintained the blood pressure, maintained the inflation of the lungs very, very stably, and likewise is able to maintain the oxygen concentration within kind of like close to room air much better than the static preservation on static control temperature preservation. Now, in our experience, what happened is our program has been growing, and as a result of growth, we have to. A lot of it came from the ability to travel further. That, as I mentioned before, introduces significant variability in our equation of kind of dealing with the donor and the recipient. On top of that, on the recipient end, we have a very high acuity recipients. Almost 50% of our recipients actually get max points for the acuity. So we transplant very sick people, and we're not wizards. If we are to maintain the excellent outcomes that we've always had, now we need to mitigate this risk somehow. So enter the Beauregard. Beauregard is simple, as I mentioned. It's widely available. It's very strong support nationwide. From the standpoint of the simplicity, even the person who goes on a procurement once a year, like myself, I'm able to use it with no major difficulties. And what we notice anecdotally, what I notice is we get a lot of pictures from the donor lungs. in the donor hospital, and I brought out one. This is the same lungs, kind of like after being stored in BioGuard for about 10 hours. You can see that all the atelectasis is gone. So there is an anecdotal evidence that it really does help with recruitment. And I was going to share with you some case studies from our institution. So, for example, one of them, we had logistical challenges, the usual kind of like we get a phone call, we have to go to the OR now. Would you take this donor? Fortunately, we had a procurement team, outside procurement team available, and the BioGuard was available. So we took it, and the donor lungs had significant atelectasis, but by the time it landed, it was actually, the lungs looked pristine, it got transplanted, and the patient did great. The other study is a little different. So this is kind of like, it was a planned procurement. We were taking the lungs from Wisconsin, and it's an appreciable travel for us. As you know, Wisconsin is a relatively flat state, one of the flattest in America. On the way back home to San Diego, the plane had to land. It was a little bizarre planning, and the plane had to land in Denver, Colorado, for de-icing, which kind of like threw me off because I thought that's where the planes go to get ice. But well, nonetheless, we landed the plane at Mile High, and as you can see, the pressure curve stayed nice and flat. There were no changes. Again, our recipient did great. The third study, there was nothing special about the travel, but the interesting thing was with regard to the recipient. Now, lately, a lot of our recipients in Southern California are silicosis patients. So this particular patient had a silicosis complicated by pneumothoraces. He had 4 pleurodesis on each side. Now, the argument, of course, only one worked, but it worked really well. So this chips that I took a picture of, this is pieces of the pleura that we had to actually remove to get in the chest. So obviously stressful case, but during this time, the cooler was the BioGuard, the lungs were sitting in the operating room, and I had no worries at all about what's going to happen, what shape the lungs are going to be in when we pull them out of the cooler. And the recipient did great, went home in less than 2 weeks, so kind of like back to real world. Now, for those who know me, I'm an avid scuba diver. My family is scuba divers. So the topic of the barotrauma comes up quite often, and it's one of the kind of like, for people who don't scuba dive, it's much underappreciated risk of diving. The risk of shark attacks is greatly exaggerated. The barotrauma is significantly less so. So, but of course, the BioGuard is designed to prevent the barotrauma in the lungs. It works very similar to what we do as a scuba divers. We try to equalize the pressure in the lungs to the pressure outside of the chest. And that's, from our standpoint, from the programmatic impact, we have a very encouraging experience with the system. Based on our clinical results, based on at least anecdotal evidence, and the lungs seem to be better inflated when they come out of the storage, and it's a tremendous ease of use. We're able to monitor the trends, and I'm going to be honest with you, kind of like as the time goes on and the familiarity goes on, familiarity with the system increases, I check the trends less and less in my clinical practice, but it's important for the research applications. It does mitigate the impact of long distance travel, longer ischemic time, and it certainly minimizes logistical hurdles and headaches for us. and it brings an increased standardization to our clinical practice. It's been a tremendous tool for us, and it's been the company has been a great partner, and it's been really wonderful to work with. So we'll save the questions to later.
Thank you, Dr. Golts. It's now my pleasure to introduce Dr. Asishana Osho from Massachusetts General and Brigham Hospitals. He's a cardiac surgeon and associate professor of surgery at Harvard Medical School. Dr. Osho.
Awesome. Thank you, Mary, and thanks for the opportunity. It's great to see you all here in Toronto. So you've heard some about temperature and some about pressure, and seeing what Paragonix and Attendees are doing to really optimize the care that our patients receive getting lung transplant. I'm the logistics guy, and really sort of thinking about how we put it all together to really impact the care of patients and do other things like improve the lives of surgeons, perhaps even decrease costs. So there's really a multifactorial, multifaceted approach to improving lung transplant that I think is improving the field on multiple levels. I'm bringing this from a context of a program that's grown recently. So in 2022, I finished fellowship, and we're about a 20 to 30 lung transplant program a year. And in the subsequent 4 years, we've gone up to doing almost 80 or 90 transplants a year. And you can imagine what this does in terms of organizing logistics and making everything work. In the middle of this, CAS, as you heard about, was started, and that's also changed our distances significantly. So those bar graphs on the left show that, previously we were mostly living in the less than 250 nautical miles. But since CAS, it's really blown up, and we're spending a lot of time, more than half of our time, over 500 nautical miles, and perhaps even more than 25% over 1,000. And then there's been more considerations for us. So it's no mystery that we've recently gotten married to Brigham Women's with Mass General, and as we figure out each other in terms of who snores and who doesn't do the dishes and things like that, and it's all coming together, and it's becoming a really big transplant program. We're talking 350 thoracic organ procurements a year. We have 3 recovery surgeons, but sort of like Dr. Gold said, it's nearly impossible for them to do all the work. And really, to get 80 to 90 lungs done per site and over about 100 hearts across both sites, we really needed support and help, and Paragonix has been there to help us with some of this. Reframing this again, this is what our maps look like in terms of where we went in the earlier part of our work. So mostly New England, venturing into the Midwest in the initial period, but then over the last several years, this is what it looks like now. Not to make this a competition, but I'll point out that our graphs show that we do go to California, including San Diego, and Dr. Goltz's didn't actually reach New England. So, what is not shown here, though, because these are OPOs, is that we did get some lungs as well from places like Alaska, and which was also followed by a call from the Toronto General Group as to why we're flying organs across Canada to get them to us. So it really does expand what you can do when you have the right type of technology. I don't need to emphasize again what the BaroGuard and LungGuard temperature and pressure controls let you do, but it really is a wonderful time to be in the business. But this is not unique to us. This is all through the country with growth in DCD donor use and what's happening at the OPO levels with CAS, like we discussed earlier. The demand on surgeons and procurement surgeons, on transplant surgeons on the implant side is not trivial. And programs have to change and adapt to being able to make this work at different hours. Again, you've seen some of these curves before, but DCDs are going up, transport distances are going up. The work is getting harder. Paragonix has worked with us to really make our growth doable, and I think it's worth highlighting a lot of the things that they offer. On the logistics side, the 24/7 procurement services have been excellent, and it's things like that phone call that Dr. Golts highlighted earlier that, we're going to the OR in an hour, how do you make this work? We're in California, and we're trying to figure out how to do it. How do we get a surgeon there and things like that? But with Paragonix, because of some of the regional things that they've done, they can get people out there quickly and make some of these donors possible. The advanced preservation devices, again, I won't emphasize that because that's been spoken about a fair amount, but LungGuard and BaroGuard are great devices papers with great data coming out on them, and they really help to decrease some of that variability. You know what you're getting for the most part. The digital platform is critical. We remain, moderately anxious people as transplant surgeons. You want to know what's going on as it's happening. So being able to get that real-time feedback from the organs is just incredible. You can track exactly where it is. You know when to start your operation and things like that. So it really has emphasized and enhanced what we've done. Going away from our general work to the things that we have done with Paragonix, showing some of these graphs. These are the lungs that we've gotten support from the Paragonix team on. And again, you see that it's really expanding our reach, not just from the Midwest and the Northeast, but really all the way out to the West Coast and beyond. And that's, in the last few years, 70 organs. And I think updated data over the next, by the summer, it should get this close to 100. You have seen this slide already. That a critical piece of this of going far is being able to use Barrowguard to maintain the pressures that you're seeing throughout travel, maintain those temperatures reliably over long distances, so that ischemic time and things like that are really becoming non-factors for us. It's you get the lungs and you put them in when you can put them in. And again, we use these devices reliably. Of those organs we showed, just about every single one of them has been with a device that is made and worked through Paragonix. But perhaps the one of the most exciting things from more recently is what you can do if you don't have to use a traditional model, which requires that you fly a surgeon out, they get the organ and they fly it back to you, almost always private. And the cost associated with that is, as you all know, immense. The new option here of essentially a one-way thing where there is a local procurement surgeon, in our case, frequently provided with Paragonix, the organ is flown back commercial. And at the transplant hospital, we don't have to worry about the logistics of getting there and coming back. We just ask for a time, get the organs, and they come to us at the time that we want. I'll show later in some slides, but the savings in terms of costs and the impact on the economics of things is immense. Couple of case studies of this. Recently, the 27-year-old patient with some Bactrim-induced lung disease, she'd been on VV-ECMO for 40 days, highly sensitized. So we're looking for organs really anywhere at this point because it's really hard to find. 99% of things just don't work for her. But we finally found one very far away in Arizona. We called our friends from Paragonix, and this was actually brought to us in American Airlines. It's coach. It's not that expensive. Patient was transplanted and ECMO decannulated in the operating room after 41 days. Another one, 60-year-old patient with IPF, donor identified in California. Lots of logistic challenges because the donor family had, as they're allowed to, as they should, sort of time constraints. We could not get a surgeon out there, but the Paragonix team was able to get somebody there quickly. Again, this is flown commercial with a courier. And patient did well, extubated, and 2 days later, that's the X-ray. These are not trivial ischemic times. I mean, it's 22 hours on ice or in the box in temperature control 4 to 6 degrees with Barrowguard. That was just unheard of before. This would be 100% a PGD lung, and this patient's doing absolutely brilliantly. But to put these in numbers, flying commercial versus flying private, in that first case, saved us $57,000. These are not trivial amounts. The second case, $67,000. You put them together, and the average cost, if you do this multiple times, really starts to add up. Again, as we try to do more for patients, be more economics conscious in what we do, the cost savings from this type of approach, this type of logistical support through Paragonix are just they're immense. It's tough to describe. So what can you do with this? The classical time shifting thing of no longer being able to do, or no longer having to do lung transplant at night is a classic one. But for busy places and busy surgeons, there's a lot of ways that you can do it. This is an example that probably doesn't show me in a great light, but sometimes I just want to get all the work done. And there was a day recently where I had 2 cabbages and then a lung offer. Did them both. I had a family event to go to, a family dinner, and I went. And then I did the transplant overnight. It's a little crazy because it's backwards, time shifting, if you would. But sometimes it's just what you need to do to get all the work done. And it gives you that flexibility to, I could have pushed it and done it during the day. I could have done it right away. I did it the way I did it. Lots of different options. But that range gives you just that little bit of flexibility that can improve the quality of life. Yes, I didn't sleep that well, but my partner was very happy that I made it to our birthday dinner. So if I had to pick, that's the one that I picked that day. So a lot of different things that this gives you the range to do. We're sort of giving, I think the kids call it watch this space information today. So this is another one of those, and a presentation that is going to be done later at this meeting tomorrow by Dr. Bush. But it's some of the early comparisons of data from BaraGuard and LungGuard. And, the BaraGuard works and works very well. And some of the additional benefits that we're seeing, perhaps some decrease in the need for pulmonary vasodilators, some decrease in the length of stay, and decrease in airway inflammation, which is perhaps the most exciting piece here. So there is some effect of poorly controlled pressures, and perhaps BaraGuard is helping to improve that. So watch this space. Advancing lung preservation with BaraGuard has really empowered us in terms of logistics. It standardizes the way things are done. It really relieves some of the CAS pressures that you have, with distance, with time, and we're starting to see that it's improving clinical outcomes, especially as you push your ischemic times into the far distances. So again, a lot of wonderful things in this space. In conclusion, the logistics of lung transplantation with partners like Paragonix, using devices that Paragonix and Getinge have pioneered, really improves the experience, enables flexibility for modern transplant programs. BaraGuard is really a key device in the rapidly evolving field, and the innovations that we're seeing all across are helping to improve our patients' lives and can really help to save some costs down the line. So a lot to discuss, a lot to talk about. Thank you for the opportunity, and glad to answer any questions.